Hi there. Welcome to everybody that's coming on board. This is our first practitioner webinar. I'm so excited. We're going to wait a few minutes for people to start checking in. We're getting there. This is Dr. Carol, and we are broadcasting from my dining room, which is really fun. What I'd like to do is a short case report today that's really illustrative of what we're able to do with FSM in a very short period of time. It's a patient that I did yesterday, as a matter of fact. And then after that, that should give you all a chance to type in some questions. They do that by typing it in.
There should be a button on the left-hand side of your screen. If you've got a question, you can click on the question icon and type that in.
There's a little Q&A icon up there. So let's get started. You should be able to see the slides on your screen. This was an interesting case that came in to the office yesterday. Her history was she's 53 years old, and her complaint was she had mid-back pain since she was 18. So this is what, 36 years of back pain, and in the last few years she started to associate the back pain with abdominal pain. And the mechanism of injury when she did it was she had a scoop of snow, so she was shoveling snow, and took this big scoop of snow and twisted and turned her upper back to throw the snow over to the right, I guess. So the symptoms were pain and tightness in her mid-back, rated between a 4 and a 7. Her mid-back itches a lot. She associates the back pain when it gets worse with a stomach ache in the middle of in the epigastric area, just below her sternum. And then she gets an occasional sharp pain in the left upper quadrant. Feels like it's deep inside, like her intestines get stuck. And she associated that with food she ate or quantity of food she ate. So she's a functional medicine patient for a long time. So she knows about diet and food allergies, and she's figured that this epigastric pain is due to food sensitivities. She gets hives, or not. She used to get hives. Now she just gets acute, intense belly pain when she eats, especially broccoli, eggs, and milk. Egg yolks she might be able to tolerate, but egg whites not. Those of you that remember Vince Marenkovich back 15 years ago, when patients are allergic to the brassicas, especially broccoli, you go looking for allergies to dust and mold. And she confirms that she has sensitivities to dust and mold. So her immune system is jacked up, and she's developed antibodies to broccoli, eggs, and milk, at least, that appear to be IgE in nature. She doesn't get hives anymore, but she gets acute abdominal pain within 90 minutes of the time that she eats. She's had endometriosis and terrible periods since her teens. She had one surgery in 2012 to remove the scar tissue. She's had 2 pregnancies and 2 miscarriages that followed that surgery. She's perimenopausal now, using progesterone cream the last 2 weeks of her cycle. Advil helps her back pain and her stomach pain. The antacids do not help her stomach pain. The inflammation and the pain episodes coordinate with her period, so they're worse than the 2 weeks before her period. She's a writer. She spends many hours a day typing, writing on the phone, sitting at a computer. She's very slender, very fit. She's the perfect functional medicine patient. Exercises on a regular basis, drinks 2 glasses of wine a week. She used to drink 1 glass a day, but figured that was too many carbohydrates. So she has a glass of wine Saturday and Sunday, just on the weekends. She has Gilbert's syndrome, slight elevation of bilirubin, very slight elevation of liver enzymes, but she's she only has one of the multiple genes for it. She's on no prescription medications except the topical compounded progesterone. Her supplements include turmeric, essential fatty acids, vitamin D, and a multi. She fell down the porch steps as a child, cracked her head. No history of abuse or sexual trauma as a child or an adult. She has a family history of cardiovascular disease on her father's side. So the physical exam, so I already have an idea of what I'm looking for. The mid-back pain and the mechanism of injury suggested that she had a disc bulge at about T5 to T7 in there someplace, given the pain pattern and her stomach pain. So I went looking for a disc bulge, and there it was. She had very hyperactive patellar reflexes, but she had general hyperreflexia that she has had since her teens. So that was interesting. Her sensory examination, all the dermatomes were normal, except T5 through T9 on the right and T5 through L1 on the left, both along the spine and out in front on her abdomen and chest. When we started doing an abdominal exam to look for the abdominal adhesions that she described from the endometriosis and that were addressed by the surgery, we did the abdominal exam and accidentally found, or coincidentally found, a tangerine-sized, very tender ovarian cyst on the right lower quadrant. And then as we worked up the abdomen to palpate the liver, and that tender spot over on the left, just under her ribs, discovered just by approaching the area of the breasts that her breasts were extremely tender. So that was interesting. So my working diagnosis was disc bulge at probably T6 or 7 with neuropathic pain in the dermatomes that I just described. And we're going to make these slides available to you. We can email them to you. They'll be sent as a PDF. So I wanted to be able to run the concussion protocol because she had that smack on her head when she was a kid. So I needed the AutoCare to do that. And I wanted to be able to treat the nerve virtually immediately, nerves. So we put the AutoCare 1300 and the Precision Care were set up in warm, wet washcloths lengthwise down the spine from about T4 to L3, so we'd cover them. And lengthwise down the front from the clavicle to the umbilicus. There's a few typos in here. And the AutoCare was set up first on the concussion protocol and in the pain. And then once the concussion protocol is finished after about 35 minutes, the pain section disc subacute to treat the disc in her spine. And the Precision Care I just set on 40 and 396 to get the nerves to be quiet. So that's what we did on the chest. And that you see how you can combine an automated unit. You could use a custom care or an auto care, even a home care or pain care to run the concussion protocol. But it was nice to be able to switch from concussion to disc to nerve when I needed it. So the setup was actually in the thoracic spine. So this shows a lumbar disc. These these were actually set up more like this. With one contact, we actually used washcloths because it was only about a 7-inch area. So the washcloths went from her clavicle to her belly button and along the spine from just below her shoulder blades down to about L3. So the red and green leads were in the back, not that it matters. Black and yellow leads were in the front, not that it matters. And we ran 40 and 396 on the Precision Care. And once the concussion protocol was finished, we ran the disc subacute protocol. And that protocol starts with 40 and 10. And she was relaxed and just sort of blinked her eyes a little bit with the concussion protocol and 40 and 710, inflammation in the disc annulus. When the AutoCare kicked in and ran 40 and 10, she's flat out fell asleep. She was not able to chat for about 10 or 15 minutes. So that's how that was done. So we were running concussion and nerves. And then after I worked on the scar tissue in her abdomen, when I went to look for that area in the upper left that she complained of and thought that it was her gut, when I treated the gut, nothing happened. So I thought, well, this is about the area where that T6 nerve root would come through, and maybe it's just gotten adhered. Okay. Kevin's going to answer that. So we did scarring in the nerve, and that relaxed that whole area of tenderness and released the tight muscles under the diaphragm. And it was just where the nerve ran under that lower T7 rib, I think. So then the next part of the treatment, so we had my old blue box, my precision micro, was set up on her lower abdomen with a washcloth on her sacrum, another washcloth on her abdomen. And that's when I found the ovarian cyst. It was about the size of a tangerine, and it was very tender to touch. You couldn't touch her abdomen. So it was 40, I just ran 40 and 7 inflammation in the ovary. And the really fun part is that she's so aware that when the pain in the ovary went down in about about 30 seconds, but when it was gone at 2 to 3 minutes, she was just blown away. That was really fun. She said, how do you do that? So I explained a little bit about resonance and how it works. And then we started to work on the scar tissue that was there from her previous surgeries. So just 13 and 77 to take, scarring in the connective tissue to take care of the abdominal adhesion on its own. Then there was a tight spot over between the ovary and her sigmoid and descending colon, 65, and then 34 is the uterus and 37 is the bladder. And then the ovary, we knew because she has so many cysts, the ovary and the tubes were all sort of scarred down to those places. And those frequencies with some manual work on both sides caused her whole lower abdomen to loosen and become just quite soft and non-tender. The endometriosis you could feel where it was just tight and tender in the abdomen. So I ran 284. Endometriosis has a lot to do with basically blood clots that are left behind. So I did 284 and 62, the arteries, 155, the endometrium, 34, the uterus, and 142, the fascia, because that's kind of what makes the pain, the abdomen painful. And that made her belly warm and took away the really heavy feeling that she had. That took about 15 minutes. And by then I was sort of done in the lower abdomen. I worked up into the middle part of the belly where her irritable bowel was most apparent. Her abdomen was pretty tender and tight. And so I ran 40 and 22. And the small intestine just quieted down and everything got soft. I ran allergy 9 in the small intestine 22. She had described herself as having leaky gut. And so I ran 124 and 22. And I forgot to put on this slide that's after I treated the small intestine, there was still an area of tightness that was like superficial to the bowel. And that was sclerosis in the adipose, 3 and 97. So where the omentum sits down in between the intestines, we have a phenomenon where the adipose gets inflamed and inflammation leads to fibrosis and scarring. So after the irritable bowel, we did 3 and 97. And then by then my hand was up under her ribs and her liver was tender. So we knew about the Gilbert's and her slightly elevated enzymes. So I ran 40 inflammation in the liver and toxicity in the liver, 35's the liver, 57, 900, 920. And that made the whole liver side just totally relaxed. So that was fun. And by now okay, and this is what we ran for the ovarian cysts. This is from the core seminar. I just ran 40 and 7, just inflammation in the ovary, and then treated the scar tissue from the previously ruptured ovarian cysts. Now, ovarian cysts are an estrogen and progesterone balance problem. In general, it seems to be more pronounced in endometriosis and ovarian cysts. Both tend to be more pronounced in women that can't convert B6 as pyridoxine to the active form pyridoxine 5-phosphate. In people that have a history of estrogen-related endocrine issues like ovarian cysts, endometriosis, breast cysts, a month or 2 trial of P5P, lower end of the dosage, and they have to take the P5P in the morning. If they take it at night, my experience is that they get a little bit too jacked up, gives them too much energy. So I give it in the morning. We treated the scar tissue. We'd already run the concussion protocol on her. So then the endometriosis was just 284 in the fascia, the blood supply, the blood vessels, and 155's the endometrium. And then there's where I ran sclerosis and the adipose. One of the things you'll notice in the slides that are up is many fewer frequencies than appear on the core seminar slides. So what's happened in the last 5 years is I use fewer frequencies, maybe for a little bit longer periods of time, and they're more focused on the problem issues that are going to have the most benefit, most bang for the buck, do the most to relieve the symptoms that bother the patient in the least amount of time. So in a perfect world, you'd love to run 294, 321, and 9 and get the whole thing sort of rebooted and fluffy. But my recent experience is that if you take the major pathologies out, the body and you run the concussion protocol, the body kind of figures out what to do on its own and reboots everything. So I tend to use fewer frequencies, sometimes for longer periods of time, but sometimes not, just more focused on the problem. So we got into the left upper quadrant area of complaint, and I treated as she suggested, which it was as if the colon was stuck and that there was an adhesion up there. Well, I did scarring in the connective tissues, scarring in the transverse colon, 16 and 27. Nothing changed. So one of the things you've all learned by this time is that if the treatment doesn't work, it's because you're treating the wrong thing. So I noticed that this area is in the T6-7 dermatome, and I switched the precision to 40 and 396 and treated the nerve. That area got softer, and then we did scarring in the nerve, and the area softened and began to move. When I started mobilizing the left side more aggressively and rocking her ribs and rocking her trunk, the right side felt tight. So you know those thoracic nerves are a circle, right? And they go in between and below the ribs, in the fascia and below the periosteum. So we used 13 and 396 and mobilized the right side, and that took care of that. So we'd already treated the ribs, the liver, I think. And as my hands moved up to the lower ribs, I just barely contacted the lower edge of her left breast, and she flinched, jumped, said, "Ouch." And I said, "Are they that tender?" And she said, "Absolutely. They're, especially this time of the month, but they're always tender. They've been tender for years." So I put the washcloth from her abdomen, or from the one that was on her back, back to front with the nerves, put that across her breasts, and on the precision care, switched it to 40 and 500, inflammation in the mammary glands, and that reduced the tenderness somewhat. But if you palpated at all deeply, she's still very, very tender. 40 and 97, the breast is what, 70, 80% adipose. So inflammation in the adipose, that took the tenderness down. So we're palpating the breast and moved along to the lateral edge of the left breast, and she had a cyst about, I don't know, the size of a kumquat, a large grape on the outer quadrant of the left breast, and there was a matching one on the right side. And 40 didn't change them much. So back, I don't know, 15 years ago when I treated breast cysts, the frequencies that reduced the size of the cysts were the ones for toxicity. Inflammation and cystic condition didn't do anything. So 57, 900 didn't do anything. So 57 and 920 with 500 for the mammary gland and 97 for the adipose, and the cyst literally disappeared. 900 had no effect. So the concept to get across to you is that the breast tenderness is inflammatory because of the inflammatory byproducts of estrogen metabolism. Breast cysts have something, I don't know what, have something to do with toxicity in the adipose or the breast tissue. So, and then she was commenting that she got mammograms every year because of these fibrocystic breasts. So I couldn't help myself. I ran 54 to remove radiation and 10 for radiation poisoning on the mammary gland and on the ducts for just a minute or two each, just as prophylaxis. And then I used 40 and 116 for 4 minutes at the very end. So at the end of that portion of the treatment, she was completely pain-free in the breast tissue. Her back was normal. I did run 51 fibrosis in the mammary gland and the fascia to soften up the tissue, and gave her the estrogen support with P5P, and then we'll see how she does in a month. So the outcome was that got her up, got her awake. Actually, to get her up, I'd taken all the machines off her, and but she was still so sleepy that she couldn't come to. So I grabbed the gloves from the Precision and had her, so I took them off the cart, put them in her hands, and ran 49 and 90, so to wake up vitality in the forebrain. 90 is the forebrain, 49 is vitality. Vitality in the forebrain, and that got her blinking, got at least her eyes moving. And then 6.8 and 38 for about 2 minutes each, and then she was fully awake and alert. When she sat up, I redid the physical exam. Her reflexes were still a little brisk, but the sensation was normal at the end of the treatment. The abdominal pain was completely gone. She was able to bend over and pick up her shoes off the floor without any pain. The abdomen was soft and non-tender in both the digestive area, the liver, and the reproductive areas. The breast tenderness, when she put her bra on, that was really funny. The breast tenderness was completely gone, and she'd had it for so long it just felt kind of strange. And her back pain was gone. All the tightness was gone. So I gave her so what do you do for follow-up? I'll see her in about a month. She lives about an hour away, so this is not a twice-a-week forever patient. Patients with ovarian cysts, endometriosis, and low levels of inflammation get worse with menses, have a problem with being able to activate B6. So the only nutritional thing that I was suggesting adding was to switch to the active form of B6, which is P5P. And she was willing to do that. That was good. And then to allow the disc to heal. I mean, she has a disc that was injured when she was 18. And posture and her prolonged sitting sort of hunched over at a computer was what was perpetuating and re-injuring the disc on pretty much a twice-a-week basis. This has been chronic for, I don't know, how many years was that? 36. So we talked about posture, how to sit up on the edge of your chair, drop your knees down, stick your belly out, to get your ears over your shoulders and keep your thoracic spine straight so you're not curving forward. Flexion in the thoracic spine is going to cause that disc bulge to constantly break open. And then gave her very small excursion. She'd seen a chiropractor who gave her huge exercises that kind of made her worse. And then she had a PT as a family member, and he gave her exercises that were a little bit smaller excursion, but still didn't seem to help much. And so the ones I gave her were the ones I learned at New Heights from Jody and the rest of the New Heights team. And that is to just contract the multifidi and the rotatories, the very deep, close to the spine muscles, get them to contract to increase circulation and strengthen and stabilize that area. Well, the disc herniation inhibits those muscles. So when we did the exercise, she got 2 contractions. When she was seated, she got 2 contractions. And the third one, the muscles were exhausted already. They couldn't find it, couldn't contract. So then I showed her laid down prone on the table and showed her the exercises for the thoracic spine when you're prone. So she put her hand on my back, and you basically initiate movement of the thoracic spine into extension. You don't actually move, because a big movement would require the big muscles, and that will turn off the multifidi and the rotatories. So I just thought about and lifted my clavicle about 3 millimeters, and that caused the thoracic muscles to contract. And then she laid down and was able finally to find those muscles and get them to contract. And she's agreed to take a 1 or 2 minute break every hour during her work at the computer, set a timer, because the discs are like sponges, right? They're water filled. It's cartilaginous, but it's water filled. So when you bend forward all day, the water goes out of the disc and it gets stiff and dry and brittle and more likely for the annulus to crack. So if you sit up, water to flow back into it, and it rehydrates the disc. Most disc patients, we have 2 types. Discs in the neck and upper back tend to be worse in the morning because the inflammatory products have pooled around the nerve root. But there's one class of discs where the patient is better in the morning because the gravity is off of the disc overnight and they're able to rehydrate and the water flows back in. So I treated her for, the history took an hour, hour and a half, about an hour. And the treatment was about an hour and a half. But she was my only patient for the afternoon, and we had time to do that. And she was basically fit and healthy. So we could get away with making these kinds of profound changes because she could accommodate to them. So it was an hour and a half. And what I told her was, in a normal busy practice, this would have been 3 or 4 sessions. You would have done the disc and the nerve first because that was her primary complaint, and she would have been happy. And assuming she lived 20 to 30 minutes from your office, you'd have her back 2 or 3 days later, and you'd work on her abdomen and the abdominal scar tissue. And then the following week, let's say on a Tuesday, you'd work on the disc and the nerve again, make sure she's doing her exercises, double check the cyst to make sure it's gone, and then work on the breast tenderness if it was still present. It was going to be present. Her breasts were constantly tender for, 20, 30 years, so no reason to expect that was going to go away. So I was able to see and demonstrate and do in 1 hour and a half treatment what in my busy clinic with multiple rooms I would have done in 2 weeks over 4 sessions. Okay, so just because I discuss this as one treatment, there's nobody in our kind of practice, our kind of medical world that has the time to treat for this length of time. The fact that this patient came from out of town and she couldn't come back is the other reason I did it all at once. So this case was so much fun to see the look on her face when she was able to bend forward and pick up her shoe without her belly hurting, without her breasts hurting, without her back hurting. It was a kick. It was really fun. So the reason I use this as a case report for this webinar is to give you an idea of how you can combine equipment to be more efficient. So in point of fact, you could have worked on the disc and the nerve with one unit and had a second unit just running 40 and 7 to get rid of the ovarian cyst. You could treat the abdominal scarring the next week and just get rid of the cyst and relieve her lower back pain. So if you have two pieces of equipment, and one's a custom care, you just program on a custom care as a single frequency combination, 40 on channel A, 7 hertz on channel B, have it run for 30 minutes. You don't have to run it the whole time, but you can get rid of an ovarian cyst in 10 to 20 minutes without any manual therapy whatsoever. So it was just a great demonstration of what you can do on so many different systems and levels to help somebody. And then the other thing I did this week, ta-da, was I finished the consumer book. Yay! The book for consumers about frequency-specific microcurrent is called The Resonance Effect, How Frequency-Specific Microcurrent is Changing Medicine. And all of you have changed medicine. All of us have changed medicine in the last 25 years. And this book is aimed at consumers. And so far, the reviews have been really exciting. So it will be out. We'll take pre-orders at the symposium. I wasn't able to finish it by August 1st, so it won't be ready until the end of April, as far as I know. If it's ready early, yay, we'll have it at the symposium. Otherwise, at the symposium, we'll take orders for it. I don't know what it's going to cost. It's being published by North Atlantic Books, and that is their subsidiary of Penguin and Random House. So we're looking for fairly good distribution to get word out. The purpose of the Resonance Effect is to create a platform, an idea in the public consciousness, in the collective consciousness of people in the US and around the world, that frequencies change tissue, that the way drugs and nutrients work are like a key and a lock, and the frequencies do what they do the way your key fob, your key beeper, opens the lock with an electric signal, and that's the mechanism of how you're doing what you're doing with FSM. And it's the story. It starts from before I started chiropractic college, and it goes, they made me put some of my personal narrative in just so it wasn't all cold, clinical, boring case reports. So the thing moves right along, and it's the story moves right along, and it talks about the initial cases and how we tested the frequencies, and then the cases that taught us what FSM can do, and then our sports medicine connections, and then what we're doing at what they're doing at Cleveland Clinic Pediatric Rehabilitation Hospital. So it's, and then at the very end, there's that chapter, chapter 10, that is all yours. Chapter 10 is one practitioner case report after another with no text from me. It's just your stories. So my deep appreciation to everybody that contributed to that, and you're going to see it in print in about 5 months. It's pretty exciting. And then the one last thing I want to remind you about is the Advanced and Symposium at the Green Valley Ranch Resort. This is a gorgeous hotel. It's in Henderson. It's not in downtown Las Vegas. It's across the street from a Whole Foods. It's a beautiful hotel. It has a spa. The Advanced is March 30th and 31st, 2017. So it's about 4 or 5 months away. For those of you that haven't taken the Advanced before, it's hundreds of new frequencies, new treatment strategies. And for those of you that have taken the advanced before, the expert workshops are worth the trip. Simon Yu is going to be lecturing on parasites, and Simon is arguably one of the nation's top 3 parasite experts, arguably possibly the top parasite expert in the US. And he'll be lecturing for an hour on what symptoms parasites create, how you go looking for them, and then how he has used FSM in the last year or two to change the symptoms that the parasites create. Neil Nathan is one of our most popular speakers, and he's doing 2 one-hour lectures. Roger Billica is taking the year off. He is going to be moderating the symposium, so I don't have to, and you get Roger's sense of humor instead of mine, which will be a great benefit. Kim Pittis will be lecturing, and I don't have the list in front of me. So the workshops alone, there'll be the 2 3-hour workshops for those in the morning, for those of you that have been to the course before. There'll be the 1-hour visceral tract and physical medicine tract. Cliff Spohr is going to be doing radiology for the general practitioner, what to look for on x-rays that help coordinate with symptoms. Then the symposium is, Diana Cross is coming to the symposium. Rob DiMartino is coming to the symposium. Jody is going to be lecturing, Jody Adams will be lecturing the physical medicine section of the advanced. This is our 20-year anniversary. If you think about what it means that a technique like this was not only started, but has been sustained through 20 years, supporting all of you and providing you with the techniques that allow you to do what you're doing with your patients. 20-year anniversary is a big thing. I'm 70 years old, and I don't know how many more advanced seminars God is going to give me. So this might be a good one to come to. And we'll do the book signing, or at least book pre-orders for the Resonance Effect. And then the symposium, Jim Oshman is coming back. We will have the Ruth Johnston Award, and I do believe we'll have a LEAP Award. And there's a fair chance we will have another peer-reviewed published paper to reward with $1,000 cash. Remember that those of you who have case reports to write up, when those case reports are written and published, once we have a PDF of, what do you call it? A copy of the published paper, we'll support that with $1,000 reward. There has to be something in it with you besides personal satisfaction and a little bit of practice growth. So that's what I have on my end. I understand that there are some hands raised and some questions. So am I supposed to type on this? Do I type over here, or do I just answer them verbally? That's the only question I have.
Yeah, if anybody has any questions, they can.
It says hands raised. There's 2 of them.
Well, that's just if you ask something. How many people think that such and such? Okay, they can raise their hands. But yeah, right.
So there's one lady here that says Alma.
Yeah,
has it started?
I emailed Alma. Hopefully she got on.
Okay.
But if anybody has any questions, there's you can see
playback and other websites
on the left-hand side of their screen. It'll say ask a question, have a little question mark there, and they can.
Okay, on the left-hand side of your screen, you're going to see a question mark. So if you have a question, otherwise, I can keep talking, but it'd be more fun if you did. I'm going to take Alma's question out. Okay. Anybody? Q&A. Okay. Well, keep thinking. What else have we done lately that is interesting? Basically, I've been working on the book since August 1st, and my brain is a little mushy. Haven't been seeing patients much. Next year, we have a core seminar in Cleveland. We're going to the Philippines to work with a nonprofit medical kind of like Doctors Without Borders, Medical Missionaries kind of group in the Philippines with Stephen Sharp. I'm trying to get Stephen to do a symposium case report on our Philippines trip from February. So that will be at the symposium. But we're going to be there for 2 weeks treating patients with custom cares and training practitioners that can work with patients there. Power. So that's February. March, I'm so excited to get to go to Las Vegas. April, we're going to do Portland, and then at the Portland seminars in April, and we'll videotape that. We do have Roger Billica's neurotransmitter workshop, and we have the advanced and symposium from last year, the advanced from this year, and the symposium from last year. All of those are ready to be ordered, and I think they're on the website. Just make sure there wasn't anything on there. Okay. Oops. And then I'm going back to Germany for a core seminar sponsored by Heinz Reinwald and Marcus Schmeich. Anyway, the Time Weaver group. That will be end of April, first part of May. And then we have 2 seminars, one in June, one in July, someplace in there. The book promotional tours will start. August, we get to stay home, or at least we try to. September, there's a seminar. October, there's a seminar. November, I go back to Germany. And December, well, where else are we in December? Anyway, check the seminar listing on the website. I just show up. How do we get involved with the Philippines trip? Let me check. That's a good question. Email me and I'll find out. That will nudge me. I'll find out from Stephen Sharp and Mylene whether the group that's sponsoring us wants to take just 3 of us, because they're paying our airfare and hotel expenses. If you're willing to fund yourself and come, because this is a nonprofit organization, if you're able to fund yourself for this trip, then I assume it would be all right. And especially if any of you are instructors or want to take the instructor's course, the instructor training, the practicum instructor training is March 29th in Las Vegas. If you have taken the practicum instructor course, you can help us train the Filipino medics to treat their patients. They're going to be they want to treat liver disease, kidney, diabetic neuropathies, and probably various pain complaints. So that's something that isn't on that Las Vegas slide, is there's an instructor training on March 29th, and that's an important one. If you need to have taken the core seminar, you should plan on taking the advanced seminar, and we're doing the instructor training before the advanced so that you don't have to stay quite so long. But the instructor training would be useful. Great hands-on work. Oh, Alma, what are the dates for the Philippines? That's a really good question. Can I get up my calendar?
We'll send it out in an email afterwards.
I'll send it out in an email afterwards, because I can't get out. Oh, let me have my phone. I can't get out my phone right now. I can't get out my calendar right now. Let me see if I can find it on my phone. I think it is February. I put it on the calendar, but it didn't come through onto my phone yet. I think it goes from we're probably going to be leaving around the 7th or 8th, and then returning on the 22nd. So we're gone 2 weeks. That's what I know about the Philippines, but we'll send out another newsletter. Make sure that we have your new email address and your current contact information so that you're getting our newsletters. We just sent one out the other day. If for some reason you didn't receive the newsletter, let us know. One other thing to let everybody know right now, The listing is on the practitioner list for, has been free for 20 years or 15 years, however long we've had a website. And so the practitioner list is pretty inaccurate, and it includes a lot of people that are not doing, or some people that are not doing FSM currently. So we need, and the list is getting more expensive to maintain as the website gets more technical. So the web listing as a practitioner is going to become subscription, and that's going to start in January. So we're keeping it inexpensive. It's like $49 a year, I think. And we'll send out a reminder and a recruitment notice about that. So make sure we have your new email address. And then, because the way this is going to work is when the consumer book comes out, consumers will read it. Chapter 9 tells them to go find a practitioner. We want our practitioner list to be current and accurate when they do that. So that's why the practitioner list is going to be subscription, and we have 4 months to get everybody on. Okay, so the next question is, that's Philippines. Never got the newsletter. That's a bummer. Hotel info for upcoming seminars. You can, I think there's a link on our website, frequencyspecific.com. There's a link on our website where you can sign up for, that will take you to the link for the advanced course. There's a core seminar in Las Vegas that weekend before. So if you're wanting to become certified, you can take the core seminar one weekend, have 2 days to rest and play, do the instructor course, take the advanced, take the symposium. It's a long week, but it gets it all done at one time and gets you prepared to become certified. Seminars, the seminars after March haven't been added to the site yet. That's on our list. And we don't have hotels for most of them yet. So we'll work on that. And each time we get a hotel arranged for a core seminar around the country, we'll put that active link on the website so you can register for there, or you can just call the office and the office will give you the information. Yay, Alma, I wouldn't have had any questions if it wasn't for you. Thank you. Anybody else out there? Yeah, the resonance effect, the consumer book has been in the works for literally 18 years. Everybody wanted me to write a book for consumers starting in about 1998, 99, once we started to be able to treat fibromyalgia. And the problem with that is that if you go straight to the consumer, the medical community will never respect you. You never get in. So it has been a long-term plan to do the consumer book last, do the published papers first, then the textbook, continue with the research in the published papers, and then do a consumer book. When you have a book for consumers, the consumers have to have some place to go to get treated. So it's taken 18 years to develop a resource of practitioners for consumers that want to be treated. And that's what the consumer book is going to do. We're hoping that it will create a huge influx of patients into your practices, as well as a fairly huge influx of practitioners into the seminars or the textbook. So where are we? Still got 10 minutes left. Any other questions? Oh, there's a 30-second delay. So when you write your question, it takes 30 seconds for me to get it. So don't be discouraged if I haven't replied yet. Let's see. Yeah, San Francisco is, no, Hawaii. We're going to Hawaii next Wednesday. The core seminar is Thursday, Friday, Saturday, Sunday. We haven't been to Hawaii in about 5 years, and it's not likely that we're going to go back. There are only 8 people that have signed up. 2 of them came from London. Nobody came from the US, and you'd think that people in Minnesota and Wyoming and Idaho and even Portland would want to go to Hawaii at, what is the room, $169 a night, to hang out in Kona and have a tax-deductible trip. That was my plan. But people are having trouble traveling, I think. But if you have the time next week and you want to come to Kona, and we are also, for the weekend, Thursday, Friday, Saturday, Sunday is the core seminar. Monday and Tuesday, it was listed as an advanced clinical practicum, but in September, we changed the designation for this advanced clinical practicum. We changed it to a master's class. So basically, the people that come are given 3 sets of handouts. They're given the advanced handouts, they're given the numerical listing of the frequencies, they're given the Visceral Core that we did this year in, where were we? Cleveland? With ICIM. No, it was in the South. Atlanta, that's it. We did in Atlanta with ICIM. And they're given the sports laminate. So they're given the laminates as they now exist. We now have 2 specialty courses, the Visceral Core and the Sports Core. Kim Pittis will be lecturing at the advanced, and she did an amazing job with that class. It was just, the reviews were awesome. We won't be videotaping them as far as I know. So you kind of have to show up for the Visceral Core when it comes, and the Sports Core is a lot of hands-on for you manual therapists and sports therapists out there. So Monday and Tuesday, I guess it's the 14th and 15th, we have the master's class. This advanced clinical practicum was renamed the master's class because you have the laminates and then you ask questions. And we go into depth on both diagnosis and treatment of whatever it is that's of interest to you. So we talk about not only how to think through the problem. So somebody with back tightness in between their shoulder blades and abdominal pain, with that mechanism of injury, the most important thing to teach you is to teach you to go looking for the disc. So we spend some time on the diagnostic logic, the differential diagnostic instincts that, and the clues that lead you to the correct treatment quickly. And then we go into depth about how the frequencies relate, how the systems in the body relate. And that's what the master's class is. If you came over only for that, fly over on Sunday, hang out by the pool. I have to confess, the lunches in Hawaii are longer, and the afternoon course is a little shorter because we spend 2 hours in the pool at lunch, and I don't care. It's awesome. It's great. And the afternoon class is usually done in bathing suits and cover-ups. So Alma has another question. The webinar next week is not a repeat of this one. So the question is the webinar next week a repeat of this, and can we access this recording afterwards to review? Yeah, it's a lot of information. That part is consistent with me, right? So next week is not a repeat of this one. Next week is a webinar for patients or practitioners who are considering getting into FSM. It's an introduction. It's basically like what we do at the beginning of the core seminar, where we just go over the published papers and what it's good for and why you should use it and how it's going to change your life and your patients' lives and all of that. And I'm pretty sure, so if you know anybody who might be interested or might be good enough, honestly, not to put too fine a point on it, if you know anybody that would be interested in introductory information about FSM, please tell them about the webinar. Go to the website and you can sign up for the webinar on the website. And then can you access this recording afterwards to review? They'll be on YouTube.
Yeah.
How do they find it on YouTube? Just put in...
Search Carol McMakin.
Okay, so if you go to YouTube and you search Carolyn McMakin webinar.
I'll send an email out to everybody with the link anyway. So.
Okay, Kevin is going to send, as soon as we're done here, Kevin is going to send out a link. That's the link. He's going to send out an email to everybody that's been on this webinar. For those of you that are dropping out, thank you very much and goodbye. But we've got another 4 minutes, and I'll use all of it if you want me to. And you're not. Don't be sorry for your questions, Alma. I'd be talking to myself if it wasn't for you. So you're doing just fine. And the webinars are available afterwards on. Thank God for YouTube. What else? Come to Hawaii. There's only like 6 people signed up for the advanced, and that's not for the master's class. And that makes it a very nice, intimate class. But see if you can get over there and join us. It's going to be a great week. And I look forward to seeing all of you in Las Vegas for Core Seminar March, well, the weekend before the 30th. So that's like the 23rd of March. And 23rd, 24th, 25th, 26th of March is the core seminar. And then the instructor training is the 29th. The advanced is the 30th and 31st, and the symposium is the 1st and the 2nd. So that's the schedule coming up. And then I think we'll probably do book signings or mailings or give you information about the book as it gets ready to come out. So yeah, we have 3 more minutes. What else? Anybody else have any questions? It's been a pretty exciting year. We'll send out emails to everybody that was on the webinar. We're also going to start sending out reminder cards for FSM for the upcoming seminars. And PDI is going to start sending out a newsletter. Like there's a newsletter that needs to go out about how you can use custom cares to improve your patient outcomes, give your patients more control over their symptoms at home, and how you can use custom cares to improve practice revenue, all of which is a good thing. So do yourself and the patient some good. So and then the magnetic converters have turned out to be just an amazing adjunct to what we do with FSM. I have to say, I got tired of sticky pads and wraps. So I use my converter on myself every night in bed, because you just have to have those little magnetic heads within 5 inches of your body, and you can treat whatever you want to treat. Those of you that are treating nerve pain, diabetic neuropathies and diabetic wounds, that's actually what the converter was designed for, because you don't have to take off the bandages. You just put the magnetic heads on the outside, tape them to one to the left leg, one to the right leg, and treat both legs at one time through the bandages. So the magnetic field goes through cloth. So that's been a big advancement in application. I think that's it. I think we're good to go. Thank you all for coming. It's been great to talk to you, even though I couldn't see your friendly faces. I see the names. I see some familiar and friendly names. And Naomi Kelly, how nice. Marilyn, hi Marilyn. Tom Patterson, yay. See, I love this. It's nice seeing your names. Okay,